Greetings and welcome to this video on dengue fever, where we discuss about the pearls and pitfalls in the cockroach. This video is meant for physicians and completely for educational purposes. This is a comprehensive overview on dengue. We'll do this as a two-part videos. This is medicine beyond the Harrisons. Let's get started. The global burden of dengue is high. So there's a mosquito-borne viral infection with a rising impact. WHO estimate around 390 million infections per year, of which 96 million are clinically apparent cases and endemic in more than 100 countries, including the tropical and subtropical. Nearly 50% of the world's population is at risk of dengue infections. So it has a lot of evolutionary importance also. Evolved from non-human primates to humans in basically in South Africa, Africa, Southeast Asia around 500 to 1000 years ago. First isolation of dengue virus is in Japan, Ken Kimura and Susumu Hota. And in 1944, Sabin and Schlesinger isolated dengue virus 1. So, pathophysiology, it belongs to the family of Flaviviridae. Serotypes are four types, DENV1 to DENV4, which are all these four are antigenically distinct. The infection to one serotype does not protect against others. So, genome is a single stranded positive sense RNA virus of around 15 nanometer in diameter. There is a lipid envelope with embedded proteins. There are structural and non-structural proteins. Non-structural proteins are mainly NS1 to 5, of which NS1, NS2, 2 has two subtypes, 2A, 2B, and again 4 has subtypes 4A and 4B, of which NS1 subtypes is mostly common among all four serotypes and it is used for diagnostic purposes. The life cycle, it is transmitted by vector Aedes aegypti, as we all know. Target is monocytes, macrophages, and dendritic cells. It gets endocytosed into the cell and fuses with the endosome and releases its RNA. This RNA goes to the endoplasmic reticulum where it replicates and further matures in the Golgi apparatus and then released to further infect other monocytes and macrophages. So mainly the concept of dengue severity is based on the antibody-dependent enhancement. Secondary infection with a different serotype can worsen the disease of dengue fever. Mechanism because of non-neutralizing antibodies that facilitate viral entry into the host cell rather than destroying the virus. This is called the antibody-dependent enhancement, which makes the secondary dengue fever most severe. The spectrum of dengue severity. There is a mild dengue, severe dengue, and critical dengue. Critical dengue is a relatively new entity that is described only in 2025, whereas there is two other types, whereas mild dengue fever, which having only typical fever and no other major complications. Severe dengue is further classified into dengue hemorrhagic fever and dengue shock syndrome. In critical dengue, there is a multi-organ dysfunction with a metabolic derangement associated with toxemia. So clinical manifestations divided into three stages, three phases in dengue. The first 1 to 5 days or up to 7 days in case of severe cases, there can be febrile phase where there will be high fever of around 40 degrees centigrade with severe headache, retroorbital pain, myalgia, arthralgia, so-called the breakbone fever, maculopapular rash, nausea and vomiting. Then after the 5 days of illness only, the critical phase actually starts with dengue fever around 5 to 8 to 9 days to 10 days, where there is increased capillary permeability and plasma leakage, and there is fall in platelets. There is a rise in hematocrit due to leakage of plasma. There is a risk of shock, organ failure, bleeding. So this is where the dengue patients needs to be monitored very closely in order to prevent mortality. So the next is the recovery phase around the day 7 to 11 based on the clinical severity. There is reabsorption of liquids from the pleural peritoneal cavities. There will be bradycardia in this phase. The general well-being improves, although the fatigue of dengue recovery may last one more week after the recovery phase. So monitoring fluid overload is essential in this phase to prevent pulmonary edema. So again, we'll discuss about the dengue the day around the days of illness, the temperature rises and which comes to normal around the day 5. From day 6, there won't be any fever spike. There will be dehydration in the first 3 days. Then finally can lead to shock and bleeding in the day 4 to 5. Then the liquid fluid will get reabsorbed and also may lead to fluid overload in and the recovery phase. So laboratory changes, there will be hematocrit increase due to dehydration. Then it may fall, the platelets may fall, and while the hematocrit will increase, then hematocrit also decreases. Then the platelets gradually start to rise around the day 8. Viremia is high around the day 2 to 3, and it gets low, and finally the IgM starts to pick up and gets into the peak around the day 5 of illness of dengue fever. Case definitions. Dengue is categorized into probable and confirmed cases. Probable case, a clinical features considered with dengue during an outbreak, NS1 IgM positive by rapid diagnostic test. So always remember, rapid diagnostic test or CART test is not the diagnostic investigation for dengue fever. It is interpreted cautiously due to limited specificity. The confirmed case of dengue should have a clinical feature plus ELISA positivity, NS1 ELISA positive, IgM ELISA positive, or positive dengue culture, IgG seroconversion with fourfold rise, or PCR detection of viral nucleic acid, of which the dengue NS1 IgM ELISA is the most commonly done investigation to confirm dengue infections. So again, classification of dengue fever: mild, moderate, and severe dengue. Without warning signs, with warning signs, and severe dengue. In without warning signs, there won't be any capillary leak. There can be rash, nausea, vomiting, myalgia, arthralgia, headache, high-grade fever, and leukopenia. Whereas in warning signs, the patient may have abdominal pain and tenderness, peritonitis. Then there can be persistent vomiting. There will be clinical fluid accumulation as evidenced by ascites, pleural effusion. There can be mucosal bleeding. There can be lethargy, restlessness, hepatomegaly. There has been rising hematocrit with a rapid drop in platelet count. So even when any of these findings are present, you have to label this as a moderate dengue or dengue with warning signs. Severe dengue, there will be severe plasma leakage. There can be shock, also called the dengue shock syndrome. Severe bleeding can be there. Severe organ involvement with liver failure, myocarditis, and encephalitis. So this is also called dengue hemorrhagic fever, the term not used now. This is a severe dengue fever. So next, there can be atypical presentations in case of dengue. Not all dengue fever just presents with fever. Some presents with just encephalitis, seizures, and meningitis. Some present directly as ARDS, atypical pneumonia. Still remember a 19-year-old female coming with sudden onset breathlessness, ARDS, and in severe shock. And finally, everybody were thinking about the cause, and finally doing a dengue NS1, it came positive. Meanwhile, the patient was dead. So GI and hepatic manifestations can happen. Most of the cases of dengue fever will have mild elevation in liver enzymes. Transaminase will be present. Liver supportive medicines can be given in this stage. Try to avoid paracetamol if there is high elevation of AST and ALT. There can be pancreatitis in case of dengue. There can be acute liver failure. AKI, interstitial nephritis can be present in case of dengue fever. There can be dengue-induced myocarditis with reduced ejection fraction. There can be pericarditis. There will be pericardial effusion due to third space fluid loss, capillary leakage. Yeah, HUS-like symptoms can be present. There can be bleeding diathesis. So these are the warning signs as we discussed previously. There will be severe abdominal pain, vomiting, fluid accumulation in the pleura, pericardium, peritoneum, mucosal bleeding, lethargy, restlessness, liver enlargement more than 2 centimeter, rapid decrease in the platelets and rising hematocrit. These are the 7 warning signs in case of severe dengue. Also we call this dengue hemorrhagic fever. So again, we will discuss about clinical manifestations of dengue fever. Clinically, the symptoms are described into clinical symptoms and hemorrhagic symptoms. Clinically, we can see fever, rash, headache, retroorbital pain, myalgia, arthralgia, which are classical symptoms of dengue fever. Whereas warning symptoms is recurrent vomiting, abdominal pain, lethargy, dyspnea, altered sensorium can be present. Hemorrhagic symptoms are petechiae, which can be demonstrated with the use of a Tarnik test. Purpura can be there, ecchymosis can be present, epistaxis can be there, hypermenorrhea can be there, hematemesis or melena can be there. All these symptoms are features of dengue hemorrhagic fever. Clinical findings, there can be hepatomegaly of up to 2 to 3 centimeters. Abdominal tenderness can be there, pleural effusion can be there, ascites, positive Tarnik test. Due to plasma leakage, there can be pleural effusion, ascites, hypoproteinemia, hypovolemia, and shock. Laboratory features, there can be hemo concentration, hematocrit increase in more than 20% with the baseline, platelet count of less than 1 lakh, leukopenia from the total leukocyte count can go below 4,000. There can be raised INR or APDT more than 1.5 times the upper limit of normal. There can be transaminitis. Radiologically, if you do an X-ray, there can be mild pleural effusion, costophrenic angle blunting. There can be pulmonary edema. Ultrasound, you can see acalculous cholestasis, ascites, third space loss, gallbladder wall edema. All these are findings of severe dengue. So pathophysiology of why multi-organ dysfunction occurs in dengue is mainly the cytokine storm and the secondary immune activation to dengue virus. It increases the vascular permeability, it deranges the coagulation parameters, there can be direct organ damage. So the viral toxins not alone cause, there's also host inflammatory mediators which lead to hepatic failure, acute kidney injury, and myocarditis. So what are the diagnostic challenges? The main diagnostic challenges, we have to suspect dengue. Suspicion of dengue should be there in the endemic setup where there is a lot of dengue fever based on the history, fever pattern, and warning signs. Laboratory testing, confirmation of viral presence or immune response with the help of ELISA testing. And the pitfalls, symptoms overlap with many other illnesses like malaria and typhoid. So you have to clinically discern what kind of the presentation is this is and when to do the dengue test. Sensitivity of the test is antigen versus antibody depends entirely on the days since the onset. So we'll discuss about the laboratory treatment in the upcoming slide. So diagnostic modalities, we have 3 things where there is ELISA, there is a PCR, and a viral culture. Although the virus culture is the gold standard, but it is less commonly done due to technical demands and the time constraints. PCR can be done, detects viral RNA, high sensitivity in early infections, but it is costly and it's not done in large setups. ELISA is the most commonly used setup to confirm a dengue virus, whereas it detects the viral antigen to NS1 or match antibodies to IgM, IgG against dengue virus. So NS1 is usually positive from 4 hours of onset of the fever. From day 1 to 5 it is positive. Then IgM appears by around day 5. It can last up to 2 to 3 months. IgG antibody appears after day 7 and can persist for years, indicators of past infection. Interpretation of the test, confirmed dengue is any of these positive RT-PCR, viral culture, NS1 antigen, IgM zero conversion in paired sera, IgG zero conversion with fourfold rise. So we can only confirm a case of dengue with these investigations. If there is high positive IgM titer in a single sample or a high IgG titer of more than 1 is to 280 per ELISA or HI test, you can say whether it can be a presumptive dengue infection. It requires clinical correlation. The differential diagnosis always consider malaria with cotidian fever, with chills and rigor, and post fever sweating. These kind of patients consider malaria. If there is a arthralgia, arthritis with joint pain, stiffness, headache, suspect chikungunya. If there is rearrangement of renal parameters, liver parameters, then if there is exposure to water or fields, farms where there can be rats, or from an endemic region, suspect leptospirosis. In case of endemic region, suspect Zika. In case of fever and no other clinical manifestations, usually with abdominal symptoms, suspect typhoid. So, distinguishing dengue from other undifferentiated febrile illnesses requires good clinical context and targeted labs. So, recognition. Suspect dengue whenever possible. If it is clinically indicated, do the labs. If the lab is negative, work up for other acute undifferentiated febrile illness. So when you suspect a dengue, do the test. So lab positive determines severity, whether it is dengue shock syndrome, dengue hemorrhagic fever syndrome, admit to ICU immediately. If there is toxemia, admit in ICU or wards based on the status. If the patient is febrile, you can just discharge the patient and follow up as OPD basis. Daily assessment for warning signs is more important. Always educate the patients about the warning signs of dengue and give advice about the supportive care. Shift to ICU immediately if the warning signs appear. So importance of early diagnosis allows timely supportive care and administration of fluid to prevent hematocrit drop, platelet drop, and prevent dehydration and further prevent dengue shock syndrome. It also improves the patient education and monitoring compliance and prevents progression to severe dengue shock. So public health impact, it triggers vector control measures in the community. When a dengue case is identified, it is usually informed to the corporation municipality where they take important actions about eradication of the vector. So increases community awareness, stops the chain of transmission. So key takeaways from this video, hope you learned what is the spectrum of dengue fever. Not all cases present classically. There are atypical presentations. There are triage warning signs are present and compass for triage and escalation. Time early diagnosis saves life. So lab interpretation is time dependent. So do the test as and when required. If the patient presents on day 3, do the NS1. If the patient presents on day 6, do the IgM. Mechanism, immune mechanisms are more predominant than the direct virus damage. It is antibody-dependent enhancement and cytokine storm that causes most of the clinical manifestations of dengue fever, which drives the disease into severity. Management revolves around anticipation, monitoring, and precise fluid balance. We'll further discuss about the management protocol, the prevention strategies, the vaccination, the newer treatment modalities, and the role for steroids in the part 2 of this dengue fever video. This is Medicine Beyond Harrison's. Thank you for watching.